Hi, my name is Cheryl Rumbley, and I am the Community Liaison for Cornerstone Hospice in the Central Florida area. Today we're going to talk about hospice care. It's one of the words that people don't want to talk about. There's this fear or misconception about what hospice really is. It's that hush-hush word. But what I hope to do today is to help you understand a little bit more about what hospice is, kind of dispel some of those myths and misconceptions, and help you understand why what we hear most often is, why didn't somebody tell me about this sooner? So a little history. Hospice began back in England in the late 1960s. There was a physician there who worked primarily with cancer patients. And she realized that the system was kind of broken. When somebody had finished their treatments, they were sent home with some medication for pain and just kind of, make it on your own and do the best that you can. And together with one of her patients, they started discussing the pain that patients have. And it's not just the physical pain, but they talked about the emotional pain and the spiritual pain, the financial pain, and the psychosocial pain with relationships that each individual faces at end of life. And so they tried to develop a program that was a more holistic approach to care. And so hospice was born in that arena. She built a hospital there, and so in England, people would go to that hospital for their end-of-life care, where they were cared for 24 hours a day, 7 days a week by a team of professionals. Hospice came to the United States in the early 1970s. They built a hospital up in the New England area, but we soon discovered that people really wanted to stay at home. They didn't want to have to go someplace else for their care. And so today, 95% of hospice patients live at home, whether it's a private residence or if they're an assisted living facility or a skilled facility. Hospice even serves the homeless. So we go where people live because that's where they're more comfortable and that's where they really want to be, surrounded by their loved things and their people and their pets and just that comfortable environment. One of the biggest misconceptions about hospice is that it's for the last couple of days or the last couple of weeks of someone's life. In fact, the average length of stay in hospice care nationwide is only about 12 or 13 days. And that's such a pity. Everyone is entitled to a minimum of 6 months of hospice care. That's months. It's not days, it's not weeks, it's months. And people are surprised when I tell them that often, or sometimes we have patients in our care for 1.5 years or 2 years. Another thing that people don't realize is that about 20% of our hospice population or census actually graduates off of hospice because they start doing so much better that they no longer qualify for care. So what makes somebody a hospice patient? We look for patients who have a prognosis of 6 to 12 months or less if their disease follows its normal course. And we have that little tagline because diseases affect everyone differently. And what some person experiences a very short time frame, others, their body reacts differently and they actually stay with us longer. We have a qualification period of 90 days, the initial qualification, and then another 90-day period. And then after that, there's a recertification period every 60 days. And as long as that individual meets criteria for their specific disease, then they stay in our program. So how do we get patients into our care? Normally people are waiting for their physician to tell them that there's nothing more the physician can do and that hospice is appropriate. But there's a problem with that, and that's that physicians, although they do a really good job at trying to cure people, they're not trained very well at telling people that there's really nothing else. So many times I've heard of patients who were taking chemotherapy and right up to 2 weeks before they passed away, and that depletes their body so drastically that there's no way that they can possibly enjoy the time that they have remaining because they're sick and feeling tired and nauseous and all. And that's such a shame. When someone is a hospice patient, they're no longer seeking curative treatment. But instead, they've realized that life is terminal and that they want to make the best of the time that they have remaining. And although the physicians don't always give referrals. We'll accept referrals from anyone. So a patient can call and say, I'd like a consultation. A family member can call, or a neighbor can recommend that someone be talked to. And so when someone gives us a referral, we will go and visit with the patient. One of our nurses will go, and they look at the criteria, the paperwork for that particular diagnosis. And as long as that individual meets criteria, we can contact their primary care physician and get that referral. Because we follow Medicare guidelines, we need a second referral, and so our physicians who are on staff agree that the individual meets criteria. So where cancer was what hospice was really developed for. Today we treat patients regardless of what their life-limiting illness or disease might be. So someone who has congestive heart failure or COPD, dementia, Parkinson's, stroke, it doesn't make any difference. Hospice is available for absolutely everyone. Another misconception is that hospice is just for the elderly. But it's for young adults and teenagers and children and infants as well. So hospice embraces every individual, regardless of their sexual orientation or their gender or their religious beliefs or what their disease is. It's for absolutely everyone. When someone comes into hospice care, they are assigned to a team of professionals. And that team includes the physician, who frequently makes house calls. It includes a nurse, social worker, a CNA, home health aides, bereavement counselors, chaplains, and volunteers. And that team gets together on a regular basis to discuss every patient that's in their care, because the CNA might hear something that the social worker needs to know about, or maybe the social worker sees that there's something that the volunteer team can help with. So what does each one of those disciplines do? The physician, of course, is making sure that that individual meets criteria and assisting with pain management. And hospice physicians are experts, better than any pain management doctor that's out there. Hospice understands pain and symptom control. Our nurses are making sure that the patient is taking their medications and helping with durable medical equipment orders, things like walkers, wheelchairs, hospital beds, portable oxygen, whatever it is that that patient might need to enhance their quality of life and care at home. We have CNAs that go in and they do personal care, trimming fingernails, bathing, shaving, whatever might be needed. I had a family member tell me that what she really appreciated was that a CNA came in and shaved her dad every day, because he had always been very dignified. And if he reached up and felt stubble on his face, it agitated him, and then her day wasn't so good as a caregiver. So just that tender care and attention to detail made a big difference in their quality of care as a family. Our home health aides go in and they help do some light housekeeping around the house, maybe the dishes in the sink or tissues in the corner, and giving the caregiver some respite time. We have bereavement counselors that work with family members, and in hospice, we work with those families for up to 18 months after they lose their loved one to help them get through birthdays and anniversaries and holidays that can be very difficult. Another thing that hospice provides is chaplain care, that spiritual side. And we're not affiliated with any church or organization. We meet people where they are, regardless of what their spiritual beliefs might be, and help them through the questions that they might have. Talking with the patient about their life and experiences, how they're feeling about end of life, things that they'd like to still be able to do or accomplish. And then we also spend a lot of time with a caregiver, because they need a lot of support. So frequently, caregivers burn out before the patients do. And so that extra support for the caregivers can keep that caregiver in a good place so that they continue taking care of their patient on the level of support that they'd like to be able to do. Hospice care is funded by Medicare, 100%, by Medicaid, 100% in the state of Florida. And many hospices are not-for-profit. The hospice that I work for, Cornerstone, is a not-for-profit. There are others that are for-profit. They have quite a little bit different business model, but in general, the hospice philosophy is the same regardless of who's providing care. One of the things that we also provide is volunteer support. And so our volunteers will go into the home and sit with the patient so that the caregiver can get out and go to an exercise class or go to lunch with a friend or go to their own doctor's appointments, do their grocery shopping or whatever, knowing that their loved one is being taken care of while they're out of the house. Our volunteers also help pull together special events and experiences for patients. We had one of our patients, what he really missed most about being sick was he couldn't go fishing anymore. And so one of our volunteers found a fisherman who had a TV show, so he had to know all the best spots. And the volunteer went with our patient out on the boat early in the morning before the sun came up. And they stopped at 5 or 6 spots, and the gentleman caught a 7-pound bass. Well, life was really good for him. It was one of those things he didn't think he was ever going to get to do again. And so that was just a wonderful gift that we were able to provide to that gentleman. So often, people are afraid of hospice, and they don't understand all the different levels of care that hospice provides. Something that many hospices provide are hospice houses, and this is a location where the patient can come when being at home isn't quite appropriate for them. Sometimes we have patients that are coming straight out of the emergency room or ICU, and they really can't go home. They need 24/7 care, and so the house provides that care for them. Our houses are also used for situations where the family dynamics are maybe just a little too stressed in the home, or the spouse really doesn't want their loved one to pass away in the home. They feel like that would be too uncomfortable coming back into the house. So they can bring their patient to our hospice house for that time. We also use hospice houses for respite care. Sometimes our families need to go out of town for a family reunion or a wedding, and the patient really isn't able to travel, and so they can bring their loved one to our hospice house for up to 5 days at no charge, so that we can love on them, and then when that family comes back into town, then we can transition that patient back to their home. Sometimes when patients are coming out of ICU, they just need some 24/7 until their symptoms are stabilized, and so they'll come to our house where we have staff 24 hours a day, and once they are stable, then we can transition them back to their home for the continued care. So our houses are very beautiful. They're more like a resort or a home, and their families are encouraged to bring pictures. They can bring the pets into the house, and we try to make it as pleasant and upbeat as possible and provide a sense of well-being for that entire family. One lady that I had talked to told me that things were a little difficult for her taking care of her her mom at home. Had been taking care of her for a couple of years, and someone told her about our house, so she came and she visited, and when they arrived, we asked what her favorite color was, and so we put pink into her room for flowers and quilts and things like that. But what really impressed the daughter was that she was so used to being the caregiver that whenever her mom needed something, she was up to go get that. And while she was at the house, our staff was the caregiver, and so she was able to just play the role of the daughter with her mom, and that made such a big difference in the time that they had to spend together there. I hope that this has answered some questions about general hospice questions, and that when you're in the class there's more detail that you'll actually have, but this kind of gives you an overview of some of the services that hospice provides nationwide. Thank you.